Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome back to another episode on the Health Trip Podcast. One of the most interesting and important areas of study that I went through in my health coaching programs was how socioeconomic disparities affected overall health and wellness. Social determinants of health are non-medical factors that influence health outcomes. Think of healthcare access and quality, economic stability, neighborhood and built environments such as parks, community fitness centers, and access to nutritious foods. Many of us don't have to think about these things because we live in well-established communities, have access to multiple grocery stores, and have opportunities to safely exercise at parks, hike on trails, and work out at community gyms. Social determinants of health affect not just our neighbors in the United States, but globally. Because my passion is serving midlife women, I am going to focus on the health disparities among women in this episode. It's an important discussion to have. I've invited a very special guest onto the podcast to help share his expertise and knowledge on prioritizing global and national efforts to make sure that all humankind have access to opportunities that lead to positive health outcomes. Dr. Bernard Toney Jr. is a former White House medical officer and global and public health professional who has developed medical plans, infectious disease mitigation strategies, and public health preparedness at the highest level of government. During his service in the White House Medical Unit, he conducted 84 domestic and 5 overseas missions in support of the president and vice president. He assessed hospital systems and witnessed the social determinants of health that led to health disparities and inequalities in the United States and worldwide. He is passionate about clinical medicine, research, education, and working with internal and external stakeholders to advance initiatives to improve global health security. Since May 2022, Dr. Toney has been with the NIH, the National Institute for Health, full-time as an associate investigator. He is a decorated Army combat veteran who served 3 tours in Afghanistan in support of Operation Enduring Freedom, and has earned numerous awards, medals, and honors. It's a very long list. Little medical disclaimer before we jump in. By listening to this podcast, you agree not to use this podcast as medical advice or for making any lifestyle changes to treat any medical condition in either yourself or others. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any of my guests on my podcast. So sit back, open your minds, and let's dive in with Dr. Toney. Hi, Bernard. Welcome to the Health Trip Podcast. I am so excited to have you here today.
Thank you for having me.
So you have a very interesting story on how you have become the man that you are today. And I was hoping before we dive into the podcast topic that you could share a little bit about your background.
Thank you for having me, number one. And I'll go ahead and sort of give a brief synopsis of who I am and where I come from. I am a 21-year now veteran of the United States Army. I started in the Army at 17 out of Atlanta, Georgia, in some pretty distressing circumstances. Those circumstances were living in a socioeconomically deprived neighborhood of Atlanta, Georgia, in which I was exposed to a lot of violence and crime. And on the precipice of me joining the military, I was a victim of a drive-by shooting. And so my good friend, Ivan Gray, passed away in that shooting. And that was just 3 weeks before I joined the military. And that led me to this idea of wanting to go into medicine, because at the moment I was not able to really do anything for him, and that left me hopeless. And so I was already committed to joining the Army as a Russian linguist. I went on and did that for a few years, and I transitioned quickly into medicine after working in 3rd Special Forces Group out of Fort Liberty now, it used to be called Fort Bragg. And I did that for at least the linguistic side of the house. I did Russian and French. I did that for about 7 years became an officer, and then I went on to PA school and became a doctorally prepared PA and did a lot of other things in public health, global health, practicing in primary care in many settings, with a capstone assignment at the White House Medical Unit, where I served between the years of 2018 and 2022.
That's very cool. How was that experience at the White House for you, taking care of such high level people?
Well, I'll say that, everything seems enamoring from the outset, but it became just, more of just a job like anyone else would have a job. I certainly loved what I did. I also worked in the White House in some very trying times, a lot of the social and racial unrest during COVID, just a lot of different aspects of life that impacted everyone globally. And it resonated very deeply at the White House Medical Unit, where I served for almost 4 years.
Yep, I could imagine. So today we're here to talk about one of your passions is social determinants of health and how it affects the health of people, not just nationwide, but globally. And I like to focus on midlife women's health. So we're sort of going to tie those two together. And I recently came across, while I was researching information for this podcast in preparation with you, I came across an alarming yet not surprising statistic by the Harris poll from May 2023, stating that 70% of Americans are dissatisfied with their current healthcare system. And some of the findings were 56% wait more than a week for an appointment to be scheduled. 53% of Latinos have skipped the last 2 years seeking healthcare, and U.S. adults spend 8 hours a month coordinating care for themselves or a family member. I know for myself, I have private insurance, and I know that making certain appointments for myself is certainly labor intensive. So I can't even imagine how it is for people who are in more socioeconomic, diverse communities. What is your take on this statistic of all these Americans feeling so discouraged by our healthcare system?
Thank you for the question. I think that it brings up some very interesting points, and this is a very complex problem set that we have here in the United States. I've talked to many leaders within our United States government, to include senators, that have struggled with this notion of how do we improve our healthcare system. The challenge is we don't have a single healthcare system. We have a healthcare system for the elderly, which is Medicare. We have a healthcare system for the people who are socioeconomically deprived, which is Medicaid. We have people who have more socialized type of medicine, who work in the military, and that's the healthcare system that I was in for quite some time, the U.S. military healthcare system and the VA. And then we have folks like yourself who have private insurance, which is another healthcare insurance if you have employer-based insurance. And then those circles that I just mentioned are not concentric, so people fall through the gaps. The challenge that we have is we have all these very disparate healthcare systems that don't really speak well and work together very well. And then you have a very high administrative burden in our healthcare system that costs a lot of money. We spend upwards of 16% of our GDP on healthcare costs, but we have some of the worst health outcomes for many of the developed nations.
Yeah.
The challenges they're varied. There are multiple variables that go into this. But I think one of the things that I focus on the social economic side, the people who are marginalized, is how do we bring them up to a level at which they can at least get the basic healthcare services that they need. And to your point, just making an appointment can be cumbersome. I have a lot of ideas on how we can improve many of those different aspects of it, but by and large, we need a universal healthcare system. I like to point to some of the Nordic states, Finland, which is, again, not much like the United States, is comparing apples and oranges, but they have one electronic medical record system. Wouldn't that be nice if you moved from Chicago to Los Angeles and you still had access to all of your healthcare records, labs, and things like that? And so I think we need to find a way to interconnect the electronic medical records that we have in the United States. We need to figure out a way to create a more universal health solution, health-based solution as far as insurance and the healthcare system. And we need to leverage technology. One of the reasons why it's so difficult for many of the providers that are delivering that care is because we're also burdened with the administrative burdens that you deal with, note-taking, writing these cumbersome notes, all of the administrative aspects of the job. It leads to burnout, at least on the provider side. And I think that the patients are feeling that on their side as well. The lack of efficacy and the decreased satisfaction with the way we deliver healthcare in the United States.
Yeah, absolutely. It is quite the burden for everybody. And right now, there is a surge in women's health awareness, and women have mostly been not well represented in terms of the gold standard of clinical trials. And I know that that is being changed by a lot of women physicians right now who are working very hard to change that number. And when we talk about the four chronic disease states for all people, it's Alzheimer's and dementia risk, cancer, type 2 diabetes, and cardiovascular disease risk. And I want to pivot to midlife women's health and how social disparities affect the health outcomes in relation to these four chronic states. Let's begin with the social determinants of health care in terms of just breast cancer alone. I know that screening is challenging for many people. And right now there's a push for not just having mammograms, but also to have ultrasounds. And how have you seen this affected or not really working well in communities that are more challenged in terms of getting the basic healthcare that they need?
Yeah, I'll use Washington, D.C. as a use case. And this is a great question with respect to women in that intersection of these social determinants of health. And just to be clear, for anyone who don't know what that term is, it's a public health term that we use, but it's basically where you live, where you work, where you play, where you're educated, where you learn. Those are the things that have these non-healthcare related origins, but they're directly tied into your health. For many people, I'll use, again, Washington, D.C. as a use case. In Ward 7 and 8, the district is divided into 8 wards. Ward 7 and 8 is the most socioeconomically disadvantaged portion of the city. They don't have a lot of access to healthcare providers. And so that is a challenge, because if you look at, you named off some of the chronic disease states, but even maternal mortality, those 2 wards don't have access to maternal health wards. So they have to figure out some sort of way to get to the other side of the district to get to adequate care. That's oftentimes untenable, and so access to knowledgeable providers that are able to bring in some of the newer knowledge with respect to mammograms and breast cancer screening, to your point. Many women may have a lot of breast tissue, and it may be more amenable to starting off with an ultrasound or even an MRI and then leading over to a mammogram to do some more targeted evaluation. But that requires health insurance in many cases. And so a lot of these women don't have the adequate health insurance that will provide the reimbursement for such studies. And a lot of times they don't have health insurance at all. And so that's, going back to our original discussion point of having adequate health insurance coverage for all is going to be one of the rate limiting steps. Education from a public health perspective with respect to breast cancer, knowing when and how to perform your own self breast evaluations, knowing how to do that monthly, what to look for, when you should see a provider. Those things are not oftentimes taught, at a very young age. And so when we find out that a lot of these women have some sort of malignancy, it's a late stage diagnosis. And so that early education on self breast examination is very fundamental. And that's something that we definitely have to focus on. And then, medication costs, or the cost of healthcare in general, even with insurance. If your deductibles and co-pays and co-insurance and the cost of your medications are so cumbersome that you can't pay it, and that's one of the reasons why you have a barrier to the healthcare system because you choose not to seek care, that's another obstacle that we have to address. Just having coverage in and of itself does not mean that we're going to increase access and utilization.
So what are some of the things that we can do in these communities, also including rural communities where, at least the communities you're talking about, they're in these big cities, which is unbelievable that they can't get access to healthcare because it's right around them. It's the next neighborhood over. I used to live there, so I know how that setup is. Right. But what about rural America? They also don't have access to healthcare and the education component. What are you seeing there?
Yeah, I love the macro perspective. I like to look at system drivers for a lot of things, and I think that we need to do a lot more to reach those communities that, for many people, feel are unreachable. I think COVID-19 accelerated the use of telehealth, and
Yeah.
telemedicine.
Mhm.
I think that is an element of being able to reach those communities. And there's ways that we can drive more access to that. I know that broadband access is still an issue in some rural communities. But that's one way that we could, definitely bring those patients into the fold and get them the preventative healthcare evaluation and services that they need, telehealth and telemedicine. I don't think that's the end all to be all, though. I think we need to have other policy issues that are implemented both at the national and the state level to be able to bring access to care to more people. And it's going to take a vulnerability risk assessment to see where those gaps are. COVID was definitely a great example of seeing where those marginalized populations may live, why we were not able to reach them with respect to evaluations and testing and things like that. We can use a lot of that same data to superimpose, where are the risks and gaps as far as women's health, breast cancer screening, and the like. And so I think what we need to start is with good data, being able to drive our decision making, and also looking at very novel ways and new ways to be able to bring healthcare solutions to those women.
Absolutely. And then talking about Alzheimer's and dementia risk, we run into the same, and this conversation could be copied for each of these four horsemen of chronic disease states, right? Alzheimer's and dementia, we know that the risk of that is increased with people that are living in socioeconomic challenged communities. They have more stressful jobs, less sleep. Sleep is now, I believe, I forget what the list is called, but one of the essential 8 for cardiovascular disease risk. They've added sleep in the last possible year, maybe a couple years. It wasn't on there before. And now there's so much research around sleep quality. And sometimes you could have a family of 10 people living in a home that has one bedroom. And so
Mhm.
how do people get the amount of sleep that they need? How do they create that bedtime routine and
Mhm.
and and create that space for them so that they can lower the risk for chronic disease?
Yeah, these are very loaded and interesting questions. I look at when we talk about Alzheimer's disease, we know that there's a genetic predisposition. We know
Yeah.
the APOE gene is what's implicated, but not many people know their
Hmm.
genetic predisposition. And even if they did know, a lot of times they don't know what to do with that information. So I think what we need to do is we need to figure out a way to, again, going back to that healthcare insurance coverage, figuring out a way that we can evaluate people with genetic counseling and genetic screening so that it's not a cost burden on the patient. That's number one. But just because you have that predisposition doesn't mean that you're going to develop the disease. And I'm pretty sure you
Right.
know that very well as a coach.
Yeah.
And so many of the same things that we will recommend with or without the predisposition are the same. Making sure that you have a good psychological environment, that if you work in an environment that's not necessarily stimulating from an intellectual standpoint, and you don't have enough cognitive resilience, trying to figure out ways from a preventative medicine standpoint that we can bring those solutions to people. And that's a confluence between not just the healthcare system, but also your employers as well, and community-based actors and stakeholders. Stress and anxiety, those are other drivers of maybe increasing the risk of Alzheimer's disease. So looking at different ways at the community level that we can have more community level involvement, support groups. I like to, harken on digital resources, but I understand that not everyone's facile with digital resources. But even if we start in the digital space and that's what leads people to more in-person types of group settings, I think that's something that we can definitely leverage, especially when we're dealing with people who are aging or even just in their midlife years.
That's a great segue to an interesting study I came across yesterday. In 2019, there was a pilot trial. It was called the Faith App Pilot Study. And do you know this one? It was funded by the NIH and the American Heart Association. And it was an app that a doctor and a community-based leader created for this community. They were African Americans,
Mhm.
and how they were so involved in faith and religion and spirituality, and how that prompted them to create this app that would help people reduce their risk for cardiovascular disease, because the app was very health-based. So because everybody pretty much has a cell phone,
Mhm.
and people wanted to have more access in the community to information quicker. And so this app was created. I think the doctor came from the Mayo Clinic,
Mhm.
and I think she started out at Johns Hopkins.
Mhm.
Um, and it's been having great success. And now they are going to open up the app to not just this one community in Minnesota, but
Mhm.
now on a national basis to people in socioeconomic challenged areas
Mhm.
to connect with this app, learn about smoking cessation, learn about
Mhm.
healthy eating habits, learning about sleep, stress management, and the importance of community. And the whole pilot started because this community member saw that it's part of their church in the
Mhm.
community. That is what brought people together to
Mhm.
help each other, support each other on their own health journeys.
Absolutely. There have been a number, I appreciate you making that nexus between community and health. There have been a number of different studies in the past that have used church-based interventions to be able to, A, have a target audience of people that you know are going to meet regularly, but B, that they trust. So a lot of these things that happen in the healthcare system, at least for a lot of marginalized populations, they don't trust the healthcare system. We certainly saw that in COVID as well. So the community sort of centric focus, much, in the case of churches as a use case, is an excellent way to be able to get a group of people that may be at a higher level of risk for a number of different reasons, but also that they're getting information from what they deem as a trusted source. And that is invaluable when we're talking about delivering interventions, because I can sit here and give you a lot of data and I can tell you what you need to do and how to do it. But if I'm not a trusted source for any
Mhm.
number of different reasons, maybe whether I have a D or R behind my name or where I come from in the country or whatever it is, there may be a barrier to delivering that information to people who need the information. And so that's the reason why we need to have credible messengers. And if those credible messengers are coming from a community where they have trusted leaders, those trusted leaders can then be the stakeholders that will be able to drive change. It's hard to do that at a national level because every community is so different and what
Mhm.
those credible messengers look like are very different. But the concept remains the same, that oftentimes we need a bottom up, sort of framework to complement these system level drivers at the macro perspective and the policy level.
Yeah, absolutely. Actually, they were saying the community leader was saying how it took them 18 months to vet out this doctor because nobody trusted her. And she was with the Mayo Clinic, and they had all these disillusioned ideas about it in 18 months. And finally, she's become a trusted authority, and she listened to the community. They said, our community isn't the Johns Hopkins community. This is the Minnesota community. We're very different. And so this doctor was able to
Mhm.
ask all of these community members, what is your why on health? What do you
Mhm.
need and what is your why? Because like what you're saying, the needs and the whys are different across the board.
Mhm. Absolutely. I remind myself of, you know, being a soldier, and again, this is completely disparate, but I'll tie it in. Being a soldier in a foreign country such as Afghanistan, when the purpose was to deliver, health-based solutions as a global health engagement, just wearing the uniform was a barrier, right? Even if my
Yeah.
intentions were completely different. And I didn't have a rifle, I had medications. Just wearing that uniform was completely different. And so that's the reason why we have to really evaluate our communities and look at things from what we call an emic approach. That means that we're working with the communities themselves as opposed to coming to the communities from an edic approach and trying to deliver healthcare solutions without having that value-based trust system, that rapport with the people who need those interventions.
Absolutely. So let's talk about cardiovascular disease since we're still on that subject. In terms of midlife women, when midlife women go through the transition of menopause, that door to our cardiovascular disease risk opens up and increases because our estrogen is going down, and estrogen is heart protective. And there was way back in the early 2000s, I'm sure you know all about it, the WHI study, the Women's Health Initiative, which is sort of hitting the news pretty hardcore right now. And a lot of the findings are being rebunked and reversed. And women, again, can go to their physicians and have a more educated, informative discussion about menopause hormone therapy, and how to make that choice. So with the risk of cardiovascular disease rising when you go through menopause, and we have all these midlife women in socioeconomic challenged communities, what are some of the preventive things that are going on now to help educate those women? Or is it just non-existent? And then what can we do?
I think it's somewhere in between. I don't think that is non-existent, but I don't think that we're operating at the optimal level to be able to reach as many people as we possibly can. I think, just to your point, a lot of these elements of risk are the same for people who are in socioeconomically deprived areas, and a lot of times it runs also along racial lines. I think what we need to do is, again, start to evaluate where the issues are. And there's been a number of studies, at least I can speak to one that's in Washington, D.C., where it broke up the district, which is not very large, by zip code. And by zip code, you can see the life expectancy. And sometimes just by a couple of miles, 4 to 5 miles, there's a decrease in life expectancy by about 10 years. That's significant.
Yeah.
And so what drives that level of decrease in life expectancy? And to your point, cardiovascular disease is one of the #1 reasons of cause of death in the United States. It takes a lot of different things. I think, we have a lot of risk factors that are at interplay here. We have people who live in, I'm thinking of all the times that I've talked to women, because I started in women's health and primary care back in 2014. And I will tell them the recommendations to exercise for 150 minutes, at least, three times a week. I will tell them to eat a heart healthy diet if they were at risk. And we would kind of go through all of those things. But, as an early in my career as a young provider, I didn't take the time to understand that, wait a minute, if I'm telling them to exercise for 150 minutes a week, where are they actually going to do that? If they live in an unsafe neighborhood, if they don't have access to gyms and things like that we have access to, where does that happen? If they don't have parks, or if the air that they're exercising is polluted. All of those things are drivers of why a person wouldn't exercise. So my recommendations fall flat. The same with heart healthy diet and eating a healthy diet. We know the obesity is rising significantly in the United States. And that oftentimes includes women that are middle age, as our metabolism slow down and things like that. But if I make the recommendation to eat healthy foods, but you live in a food desert, and you don't have the transportation, let's say, to get to a healthy food source or a grocery store that doesn't, try to sell unhealthy foods. All of these things speak to policy level decisions that we need to work from the top and start to drive these things down. You're right. The estrogen is cardioprotective, and it is one of those things that women uniquely experience, but they're also experiencing all these other traditional risk factors that we have to address as well. And I think all of those things have to be considered in the equation when we're trying to improve the lives of others. And the way that I say that's done is with your vote. I'm not a politician, but I'll say to be informed on who you're electing to lead you at the local, state, and national level, because their interests are, sometimes in conflict with the interests of their constituents. And so I think we need to be, using our voice in many ways to have an active participation in the political sphere to be able to drive some of these policy level changes that are health focused in a meaningful way.
If someone is listening to this podcast right now and wanting to become more involved, further than just voting, what else is available for people to do in order to support these changes on a local community level?
Right. I would say that there's a lot of different nonprofits in every different city that are working, community-based organizations that are working to address any number of these social determinants of health. And again, that's not a all-covering solution for many people. But if you see that things are not being done, oftentimes what we need is leaders. We need leaders to step up and identify the unique challenges within your community, and start working to do things about it. I can point to a lot of different organizations in the DC and Baltimore area that are working on very vertical programs to address very specific health related challenges. But if those don't exist in your communities, then I think it takes active involvement to start working on those and building a guiding coalition in a way that's cross-sectoral, right? So like we can make health-based solutions and talk about public health, but if we're not including the education sector, then a lot of times we're not getting that information to the students where they need it, most readily as they grow. So being involved in your communities at every different level is going to be very, very key. A lot of these top-down solutions will take years, if not decades, to make an impact. But the most agile and the quickest solutions that anyone can make would be at the community level. And that's being involved in any number of different groups, surveying what's available as far as resources within your specific community. And when you don't see those resources available, start to petition in the right places to vector in those resources to drive change. As far as information online, there's always, we live in a technology age. So a lot of the recommendations that I would present will come from the CDC, and they have a lot of very tailored type of solutions that, communities and individuals can use. But there's also your public health departments that work within your cities as well, that can help you with the messaging, that can help you with identifying the resources to be able to drive that change. And that exists nearly in every community in the United States.
Absolutely. We all have to be involved and help our neighbors. Number one. How do you see the healthcare system and what's going on with midlife women in the United States compared to other communities outside of our country? Are there any ones that are doing it right? There's got to be someone doing a better job.
Right. Yes, and yes. But no country has it quite right. I will tell you, I'll use my own family as an example. In South Korea, my wife is South Korean, and they have a very good way of enabling women to give birth to children and being able to, to pay them some sort of compensation after they have children, and maternal leave and family leave and things like that, specific to women in their middle ages. A lot of the European states, they do a lot of things very, very well. But, I say that with the air of caution, because these countries are so different. I'll use, France as an example. I'm enamored by their healthcare system.
Yeah.
But they also have a smaller geographic area to cover. They have, and oftentimes a higher physician to population ratio. And they are, in many different ways, more accepting of a higher tax burden to be able to cover the general population for primary care and preventative medicine and things like that. So I think what we have to do is not really modeling our healthcare system off of another country, because the United States is very unique in that way. But I think we need to have a bigger discussion on where our dollars are going. As I pay taxes, I have no idea where my federal tax dollars are going. And I think we need to figure out a better way to allocate those monies appropriately, because here in the United States, we have a system of sick care. We don't have healthcare. Yeah. We have a system of sick care. And that's where the model goes from medical school or any type of, pre-service education all the way up. There's not a lot of investment in public health and preventative medicine. And so we need to figure out ways to shift that paradigm, in our education system, but also in the way our policymakers allocate their programmatic funding. And I would say that we need to focus on healthcare, because let's be clear, it's impacting all of us. Even if it's just in higher insurance costs, we're being pulled with people who have a higher disease burden. And so our insurance costs increase as well. So I think what we need to do is we need to have a paradigm shift. And that paradigm shift also comes with a different way of thinking, even for the average American, about what we're willing to pay for.
I also think that paradigm shift includes health coaches like myself. In the world of functional and integrative medicine, they're bringing in health coaches into their clinics, into their practices, using telehealth as an advantage, a benefit to their clients and their patients. But the conventional healthcare system is still resistant by using us, since we're not licensed like a nutritionist or a dietitian. I'm a national board certified health and wellness coach, so I have the highest of testing and skills of any health coach, and we are growing that community globally. But I do see the resistance still from the conventional healthcare space with my clients, when my clients want me to speak to their
Mhm.
doctor, so that we're all on the same page, which is another thing that's going wrong in this country. Everybody has a doctor for every organ or in every
Mhm.
system in the body, and nobody's talking to each other because they assume that the entire body is made up of separate systems, when it, of course, we know that it's a whole. So I
Mhm.
think bringing in health coaches into the conventional healthcare model is going to be instrumental down the road. And we have some amazing people, like one of my mentors, Dr. Sandra Scheinbaum, who started the Functional Medicine Coaching Academy, who
Mhm.
is very well known in those circles and doing so much good work for all of us health coaches to bridge that gap between a medical diagnosis and the real world. How can you walk out of a doctor's office after meeting someone for 7 to 15 minutes with a diagnosis and then put it to work in your real life, whose everyone's equation is different?
You gave us more time than we really have. 7 to 15 minutes. I would say it's probably closer to seven.
Okay.
Let's be clear. The primary care appointment is usually about 20 minutes, and the nursing and evaluation and vital signs that takes about 10 minutes. If the patient is late, you lose even less time, or even more time rather. I think you're right. I've seen this. Not to say that health coaches are completely comparable to, let's say, doulas, but the analogy is the same. Where we look at people who are able to, not that they're clinicians, but they're able to help people in a very pivotal role to be able to provide information, to be able to help patients navigate the healthcare system, to be, force multipliers for those medical providers and doctors that are delivering the care, facilitating communication, if you will, even between the patient and healthcare providers. Where the challenge lies is in the regulatory system. So how do we reimburse for that? Because we would love to be able to, it would only make sense for the healthcare system to reimburse for coaches, and for people who are not able to afford their own coaches. Maybe they live in a marginalized population or socioeconomically deprived, but they need and want a health coach. We need to have a system that's a novel way to be able to provide reimbursement for that. The healthcare system has tried to do some of that with patient-centered medical homes, where there would be like a nursing educator who would be able to see the patient after a patient received, let's say, a diagnosis of high blood pressure or high cholesterol. The provider may give them some cursory information, answer their questions, prescribe a pill, and then that patient would then go and see the nurse, who would elaborate more on the lifestyle changes and things like
Mhm.
that. But there's a paucity of that model in the United States. The healthcare system is overburdened and strained, and most people don't have access to that. So you're right. I think a health coach is definitely a viable option for being able to deliver, some of that more comprehensive medical care, to be able to tie in all the pieces of the healthcare system, if you will. It's just, I think the reimbursement of it is going to be a challenge. And the other thing is, standardizing and regulating the quality. I'm pretty sure that you're of the highest pedigree, if you will. But then how do we measure that, for people who may not have your same skill set, background, and expertise? And so the challenge, I think, for us is, how do we think through that? But to your point, I think we need to think through it. I think we need to look at all of the enablers of the healthcare system, because again, I want to pivot from a sick care system to a healthcare system.
Yeah. Well, we are working on getting codes for health insurance to pay for health coaches. So that is in the works. I think we're probably a few years away still,
That's great.
but it is in the pipeline for sure. Bernard, thank you so much for all your time today. It was such a pleasure to have you here. I haven't done a podcast like this ever, so this is very unique to my community and eye-opening, and just helps us think about our own health. You know, the struggles that we're all having. Everybody is having struggles, whether you live in a multi-million-dollar home or a one-bedroom or studio apartment with 10 people. You know, we all have our own struggles, and pivoting to make lifestyle changes are always going to be a challenge. So we all have to help take care of each other and be empathetic towards each other and those disparities. Where can people find you on social media? I know I follow you on LinkedIn, and you put up some amazing information. It is true educational, informational, loving. It's all of it, right? It's so where else can people find you if they're not on LinkedIn?
Yeah, unfortunately, I only have LinkedIn after
Oh,
spending
okay.
so many years in the government and with the top secret security clearance and working at the White House. I had a very slim social media presence and profile. So now I primarily only use LinkedIn, but that's where you can find me. No one needs to request me as a friend. My profile is open. You can follow me, and that's what works best for me. But I'm always on different podcasts, and if you just Google my name, you'll see other things that I've talked about in the past. But for a centralized point, LinkedIn is where I spend most of my time.
Is there anything else that you want to share before we end our podcast?
No, I just want to say thank you for having me. I think, again, as we collectively, if one population or one small subset of any group is disadvantaged or marginalized, then we all have a responsibility to help
Absolutely.
one another. And so I think that if we can look at life through that lens, if we can look at ways to help our neighbors, which is, one of the, values that I point to most readily in my work, in my daily life, I think we'll all be better because of it. So I would love to lock arms with anyone who would love to do that type of work. And I also am the board chair of Stepping Stones for Global Development, which works on international solutions and transfer of skills, capacity building for very weak healthcare systems around the world. So that's another way to reach out to me if that's an area of interest as well.
Oh, and so how can people find that?
Stepping Stones for Global Development, SSGD. You can just type that into Google and our nonprofit will show up. We just most recently came back from Ecuador, and I was just advising the country of Ecuador this week on some public health initiatives as they're dealing with climate change and the impacts of El Nino. So again, kind of working across the entire world in that way. But again, LinkedIn is where to find me on individual levels, and I'm willing to work with anyone if we have an area of interest that we have a mutual supporting agenda.
Wonderful. I will list all of that in our show notes so that people can find you and follow you. Thank you again so much for your generous time and talking about this delicate conversation, this delicate topic for everybody.
Thank you so much, Joe.
Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.